moderated by our mentor, our teacher, and a trainer of our trainers, past president of the West African College of Surgeons, in person of Professor Yahweh. I also recognize presence of some surgeons in our midst. Dr. Ghazali, a hepatobiliary surgeon from Aminu Kano Teaching Hospital. So you are all welcome to this session of the presentation. So I will hand over to Professor Yahweh to take charge of the presentation and moderate. Prof, you are welcome, sir. Hello, good evening, Prof.
Good evening.
You are welcome, Prof.
I think, yeah, thanks. I don't know whether the problem was my network or the other side, but it suddenly went off as you were introducing the...
Okay, it's back, sir. We can hear you, sir.
Yeah. In a location down south, you're right. So you can start.
Good evening, Prof.
I don't know how many people on the call, about 13 people on the call.
Sir?
Good evening.
Dr. Sholade, you can start.
All right, sir. Good evening, Prof. Good evening, consultants, my fellow registrars and registrars. I'll be presenting the current trends in the management of breast cancers. My name is Soladoye Abdulmajid Adebayo, and my moderator is Professor Kedito Yahweh. I'll be using the following outlines for this presentation. I'll introduce the topic. I'll talk about the diagnosis, the early diagnosis using the risk assessment tools, triple assessments. For the treatment, the early breast cancer, the current trends in measure of early breast cancer, local advanced breast cancer, and metastatic breast cancer. Then I'll talk about follow-up of patients, the challenges we have in West Africa in this current management of breast cancer. Then I'll conclude. Breast cancer is the most frequently diagnosed cancer. It's the most frequently diagnosed cancer and a leading cause of cancer death among females in the world. The lifetime risk in females is about 12%. It accounts for 23% of the total cancer cases and accounts for 40% of cancer deaths worldwide. Approximately 5% of all breast cancers are classified as metastatic at the time of diagnosis. According to reports or published from Nigeria, especially from Luth and Ibadan, the incidence of advanced breast cancer at presentation are usually about 60% as reported in Lagos and 58.2% as reported from Ibadan. And the incidence of breast cancer in Nigeria, as reported by Olaseyinde et al., was 54.3 per every 100,000 population in Nigeria. The 5-year survival, for breast cancer was said to be 23.3%. And the most important risk factors are female, gender, and increasing age. Multidisciplinary care is now a well-established standard of care in the management of breast cancer. And this is where multidisciplinary team come together in the management of a patient who has breast cancer. The team can vary between general surgery, the geneticists, the radiotherapists, nurses, and the oncologists. A better understanding of heterogeneity of breast cancer and advancement in technology has shifted the paradigm to individualized treatment protocols tailored towards individual tumor biology, patients' unique situations and preferences. And this is what is being emphasized in management of breast cancer now, where patients are individualized and the appropriate treatment protocols are designed for individual patients for their management. The management of breast cancer now emphasizes preservation of breast tissues without compromising oncologic clearance. Detection of breast cancer has shown significant improvements in overall survival of breast cancer patients. One of the tools for early detection is the risk assessment models. And this assesses the chances of developing breast cancer over a given period of time, usually about 5 years, or over the patient's lifespan. And also, it assesses the chances of patients being a mutation in a known high-risk gene, such as the breast cancer gene 1 or breast cancer gene 2. Also, the etaxin-telangiectasia mutation or the checkpoint 2, and also the partner and localizer of breast cancer 2 are the commonly high-risk genes that are being assessed for in high-risk patients. The risk assessment tools that have been used over time has evolved from the GAIL model to the CARE model, the CLOS model, the Couch model, BRCA-PRO model, and the Tyrer-Cuzick model. The GAIL model was first published in 1989, and it uses personal risk factors in assessing the risk of a patient, where it uses the age of the patient, the race, the age at menarche, the age at first childbirth, the numbers of biopsies they have done, and histology if they are atypical, and also the history of breast cancer in first relatives. However, this GAIL model has been challenged by the fact that it is not well applicable to the Black race, the Black in the Black, and that is where the CARE model now comes in. The CLOS model uses majorly, is based majorly on family history of breast cancer in the patients, the risk of breast cancer in this patient's family, who can either be from the paternal or the maternal side. While the Couch model predicts the risk of mutation in BRCA1 gene in a patient. The BRCA-PRO model actually predicts the risk of mutation in both BRCA1 and BRCA2 gene. The Tyrer-Cuzick model incorporates both personal risk factors and genetic analysis to give a more comprehensive and individual risk assessment, which is the more and the most recently favored model for assessing the risk in patients. Women nowadays are now being advised to screen themselves based on their individual risk factors, unlike when people just go for screening, and this has helped to individualize patients' management, and that is where applying wisdom to achieve early detection is being used. It's a current model where women are being advised to go for screening based on their individual risk, like the density of their breast or even family history of breast cancer. In the diagnosis of breast cancer, the triple assessment has always been the standard for early and accurate diagnosis of breast cancer because of its high predictive value and confidence rates. Mammography is the primary imaging modality in assessing patients with breast lesions, and it has been shown to be very sensitive and specific in patient management. However, the traditional mammography that is being used is the slide or film mammography, which has been challenged by the density of and the density of the female breast, especially in the young age groups, and also the incidence of the higher incidence of interval cancers in patients with hereditary breast cancer. This has called for the improvement in the technology in this technology, so as to have better quality imaging in mammography, and that led to the development of the digital mammography. Digital mammography uses algorithm, is a form of algorithm-based technology where lesions from breast can be identified by computer, and this would alert the radiologists of these breast lesions, and detection can be faster and easier and more accurate in them. Also, to increase the accuracy of mammography, other types of mammography has also been developed, which involve the contrast enhanced mammography and the 3D mammography, also called the tomosynthesis. All these have helped to improve the quality of mammography, and also to break that that hindrance, in the sense that mammography is not so sensitive in patients with dense breasts. But with the use of digital mammography, this has been taken care of. There are features which are being looked for in mammography to make diagnosis with mammography, and these features are primary or secondary. In the primary science, mammography features is based visually on the mass lesions. The mass lesions are usually characterized. They are characterized for the shape of the mass and the margins of this mass. Speculated masses are the commonest mammographic appearance in a malignant breast lesion, which accounts for about 90% of malignant masses found on mammography. Other features that are used to characterize, that are used in mammography, are also the calcification. Calcifications are said to be found at least 30% of cases of invasive breast cancer, and the microcalcification are lesions between 0.1 to 1 millimeter and appear stand-like. They are usually clustered . Skin thickening or retraction, and areolar thickening, abnormal ductal patterns, lymphadenopathy, and asymmetry. All these features are used to characterize a lesion on mammography. The reporting was standardized using the breast imaging reporting and data system, which is the standard way of reporting mammographic images. And patients that are categorized as category 0 will usually need additional imaging evaluation, and this could be due to several reasons. And patients categorized as category 1 usually don't have lesions to be reported on it, so they are usually reported as negative. Category 2 patients have benign findings, and they are advised to continue their yearly screening, while category 3 are reported as being probably benign and have shorter interval screening, usually about 6 monthly or biannual screening. For suspicious abnormalities, which are categorized as 4, they require biopsy to confirm that malignancy, and appropriate management is instituted. Same for category 5 and 6, which are highly suggestive of malignancy and known cancers. These category would now follow proper assessment of patient, and the appropriate management would now be instituted. Because of the challenges that are met, that we see in mammography imaging, like issue of the density of breast affecting it, and interval cancers occurring in patients with hereditary breast cancers, other imaging modalities have been introduced also to screen patients with breast lesions, and this includes dynamic contrast enhanced MRI, which does not have the which is non-ionizing radiation and can detect lesions in patients who are young and have high breast densities. Others too that are used are the magnetic resonance elastography, diffusion weighted imaging, and the list continues, just to improve on imaging results from screen of breast lesions. And this is a table that shows these imaging modalities, their diagnostic accuracy, their advantages and limitations. In the triple assessment, after imaging of patients, pathologic assessment follows, and the gold standard, or the sampling method of choice that is advised for both palpable and non-palpable lesion is a core needle biopsy, which has been shown when used with image guidance to be very sensitive and specific. It is now preferred over the fine needle aspiration cytology, which was previously in use and even in some places now still being in use. But core needle biopsy is shown to be the sampling method of choice, and has even replaced some of the techniques used in biopsy, in tissue biopsy now. For non-palpable lesions, radioactive seed localization is currently being considered as in place of the self-retaining hooked wire localization. Because non-palpable lesions are usually difficult to find intraoperatively, use of needles and hook wires are used to localize where breast lesions are, and these are now used to excise the lesions. For presently radioactive seed localization, like use of the iodine 125 or titanium seed, are presently being used. And one of the part of the complications arising from the use of hooked wire includes pain and discomfort that patients feel, dislodgement of the wire, which usually requires patients to go back to the radiology for fixing of those wires again to properly locate the lesions. Intraoperative wire transection can occur, or retention of wire fragments. Sometimes the wire can interfere with the electrocautery and cause thermal injury, or interfere with imaging of these patients. The newer methods that are also used in localizing lesions are the radio-guided occult lesion localization, the fluoroscopic intraoperative nucleosome detection, and intraoperative ultrasound scan, currently being used to localize non-palpable lesions and improve on their excision. Because non-palpable lesions are, because of these challenges, non-palpable lesions are required, specimen radiography and post-biopsy mammography are usually required to confirm specimen removal in this category of patients. One of the current trends in biopsy of patients is the use of liquid biopsy. This uses body fluid to identify tumor products, and usually blood is the commonly used fluid for liquid biopsy. It's commonly used because blood is easily accessible. Frequent samples or frequent biopsies can be taken, and that gives room for patients to be closely monitored. In fact, they call it a real-time monitoring of patients. It gives room for real-time assessment of tissue samples, and it is less discomforting, like the use of the tissue biopsy. And the tumor products that are being isolated and analyzed include circulating tumor cells, the cell-free tumor products, which include the cell-free DNA, circulating RNA, and circulating tumor DNA. These molecular characterizations actually enhances customization of treatments of patients. The circulating tumor cells and the circulating tumor cells and the circulating tumor DNA are used to predict patients who are likely to have recurrence long before after the adjuvant treatment. Patients who may have metastasis, and also it helps to characterize different tumor biologies that may be in the blood of that patient. Unlike when tissue biopsies are being done, samples may be, because of the heterogeneity of breast cancers. When tissue biopsies are taken, samples may be taken on a part of the breast tissue where a particular clonal expansion is compared to other sites, and that may affect the overall management of patients, where initially patients may respond to chemotherapy, and later on there will be relapse. This problem is being solved by the use of liquid biopsy, where the overall biology of the tumor can be actually picked in the blood and helps. When 5 circulating tumor cells are present are found at presentation, it's usually a sign of poor prognosis. Aside from the standard histological subtypes, tumor grades, newer pathologic assessment defines the various heterogeneous subtypes for individualized treatment. And this newer pathologic assessment uses the molecular markers that are found in the biology of the breast cancer. And in the biology of breast cancer, it involves the steroid hormone pathway, where the estrogen receptors and progesterone receptors are strong factors in the development, in the initiation and development of breast cancers. The HER2, that's the human epidermal growth factor receptor pathway, and angiogenesis related molecular pathway. These all these are newer pathologic assessments for patients, and they all helps in individualizing the management of patients. Immunohistochemical, using the 4-panel immunohistochemistry is now being used globally as a standard for histological assessment or pathologic assessment of histological samples. And the estrogen receptors are usually, as shown of the panel, the progesterone receptors, the human epidermal receptor, epidermal growth receptor 2, and the Ki-67. These are all panels that must look out for in tissue samples in management of breast cancers, and they all have their individual roles in both prognostic and predictive values. Some other newer prognostic and predictive markers are the Oncotype DS, Mama Print assay, and the Terra Print. Oncotype DS is a 21 gene recurrence score, which is based on the reverse transcriptase polymerase chain reaction gene expression profile assay, which uses 16 cancer gene and 5 reference genes. And the genes are categorized as follows: categorized based on the proliferation, which the following genes are used: estrogen, invasion, and the HER2. The reference genes are as below. In the molecular classification of breast cancer, into lumina A, B, the HER2 enriched and triple negative. The 4-panel immunohistochemistry are used to categorize, to classify patients into molecular classification. And for patients with lumina A, they have the hormone receptors are usually positive. That's the estrogen receptor and the progesterone receptor are positive, while the human epidermal growth receptor are negative, and they have a low level of the Ki-67, which is a marker for tumor proliferation. That means, so this gives them the tumor in lumina A are usually low-grade tumors, which are responsive to endocrine therapy, and they have good prognosis. Lumina B breast cancers have hormone receptors are positive. That's either the estrogen receptor or progesterone receptor. They have high level of the Ki-67. That's they have the marker of the proliferation and tumor proliferation is higher in them, and they usually have a negative human epidermal growth factor receptor is negative. Where the HER2 is positive, they are called the HER2 luminal B. These categories of breast cancers are shown to have poor prognosis, or a poor prognosis compared to the lumina A breast cancers. The HER2 enriched breast cancers have a positive HER2 epidermal growth factor receptor, but the hormone receptors are negative, but they have a high Ki-67, and this gives this category of patients poor prognosis. However, they are responsive to some therapies which are targeted at the HER2 receptors. The triple negative breast cancers have the hormone receptors are negative. The HER2 receptors, the HER2 epidermal growth factor receptors are negative. And they have high level of Ki-67. Some people usually mix up the basal-like subtypes with the triple negative, but it has been recently shown that these categories are subtypes of the triple negative, and 6 subtypes of the triple negative are now currently identified, and these are the basal-like subtypes, which are the BL1 and BL2, the mesenchymal subtype, the mesenchymal stem-like, the luminal androgen receptor subtype, and immunomodulatory subtype. These various clonal differences or cellular differences in triple negative confers different chemotherapy responses in them. This is why some patients with triple negative may or may not respond to chemotherapy based on different subtypes or subclassifications of the triple negative breast cancers. And some other newer types are the Claudin low. The Claudin low is just like the triple negative, but they have a low level of the E-cadherin. There is also normal-like breast cancers. They are just like the luminal A, also but with a poorer prognosis. The current staging of breast cancer uses the American Joint Cancer, the American Joint Cancer Networks, is the 8th edition, and it utilizes the TNM status, biologic markers, which include the estrogen, the ER, PR, and the HER2 status, the histologic grade and oncotype DS. These are all included in the AJCC 8th edition, and is currently the staging system employed in management of breast cancer. The 9th edition is set to be published by 2024. The current trends in the management of early breast cancer Now, minimally invasive techniques are being used in the excision of breast lesions. And these minimally invasive techniques include radiofrequency ablation, interventional radiology, guided cryosurgery, and percutaneous tumor excisions. These are minimally invasive techniques which are being used to remove or excise breast lesions. Also, the current trend in the management of early breast cancer is, like I said earlier, is preservation of breast tissue without compromise to oncologic clearance. And with that, the breast conserving surgery techniques are being used, and some of these techniques include wide local excision, chondrolectomy, thalassotomy, and the rest of them. These breast conserving surgery techniques are used together with oncoplastic surgery to replace these lost breast tissues. It has been shown that there is no significant difference in the overall survival or disease-free survival in patients receiving breast conserving surgery with or without radiation compared to those receiving modified radical mastectomy. However, the rate of local regional recurrence was significantly higher in those who underwent lumpectomy without radiation. And this is why the breast conserving surgery is more favored, because there is lesser morbidity compared to when modified radical mastectomy are offered to patients in this category. Also, recently, some patients request for prophylactic mastectomy of the other breasts, and this is being done routinely in some countries. This, however, was frowned at by the American College of Surgeons, who now recommend that for those who opt for prophylactic mastectomy, the indication should be when there is strong family history, when there is the breast cancer gene mutation, or when there is the lobular carcinoma in situ, or patients who are young with aggressive disease. So currently, some people opt, despite the knowledge of the breast conserving surgery, some patients will still opt for prophylactic mastectomy. And this is where the shared patient management or shared decision making comes in, where decisions are now being made not only by the surgeon with his material of knowledge, but also considering what the patient wish or desire also is. The current trend in the management of the axilla in patients with early breast cancer usually as metamorphosed from the previous axillary clearance, where the level 1, 2, and 3 axillary lymph nodes are usually being cleared, to a less radical surgery, which is the axillary lymph node dissection. Here, only the level 1 and level 2 lymph nodes are cleared. But patients with N1 nodal metastasis are now even being offered regional nodal irradiation in place of the axillary lymph node dissection. And these two modalities have been shown to provide excellent and comparable control of this patient population, where although axillary radiotherapy was associated with less considerable morbidity. So patients with N1 nodal metastasis can even have regional node irradiation without axillary lymph node dissection, and yet have the same outcome and lesser morbidity. The sentinel lymph node biopsy is also a current trend, but here there are newer radiopharmaceutics that are being used, like the technetium-99 and the use of gamma probe in identifying the sentinel lymph nodes in while managing patients with early breast cancer. In the management of locally advanced breast cancer, The patients with operable breast cancers, which are usually the stage 2B breast cancers, are offered neoadjuvant chemotherapy to reduce the size of these breasts. The tumor size is usually T3. So after that, they are offered breast conserving surgery. For those with those category of local advanced breast cancers who are inoperable, they are offered neoadjuvant systemic therapy, which can be chemotherapy, endocrine therapy, and this management are usually assessed. The response of this management are usually assessed using some of these criteria, like the response evaluation criteria in solid tumors, where endocrine neoadjuvant chemotherapy is used. The preoperative endocrine prognostic index is advised to assess, is advised to be used to assess the response of these patients to endocrine therapy. After which mastectomy is now offered, and here usually the modified radical mastectomy is offered to patients. Then subsequently they have adjuvant therapy, which may be chemotherapy, endocrine therapy, and even radiotherapy. The radiotherapy being used in this category of patients are now treatment de-escalation. Radiotherapy treatment de-escalation is what is being offered. This is done to reduce the toxicity and duration of treatment without compromising oncologic outcome. And examples of this radiotherapy treatment de-escalation include hypofractionated radiotherapy, where higher doses of radiotherapy is used over a short period of time. The other ones are the partial breast irradiation and intraoperative radiotherapy. Patients who are offered breast conserving surgery also have a boost radiotherapy to the tumor bed. Patients following neoadjuvant therapy, patients who have clinically positive lymph nodes are offered either sentinel lymph node biopsy or axillary lymph node dissection. However, there is no role for sentinel lymph node biopsy in patients with inflammatory breast cancer. So they usually have a modified radical mastectomy with axillary lymph node dissection. This is an algorithm of how patients with locally advanced breast cancer are currently being managed, and more or less what I have actually discussed earlier. In the treatment of patients with metastatic breast cancer, the current management, the goal of treatment of this category of patients is to extend their survival, to alleviate their symptoms, and to enhance the quality of life. And patients with metastatic breast cancer are categorized into 6 for this purpose. The category 1 patients are patients with hormone receptor, patients who are hormone receptor positive, but they are HER2 negative, and there is no crisis. There's no visceral crisis, and they are not the visceral crisis that may warrant a radical or a quick treatment, and they are patients under for management of metastatic breast cancer. The category 2 patients are patients who are hormone receptor positive, but they are also HER2 negative, but they have visceral crisis, or they have endocrine refractory disease. These category of patients require an urgent management, so they may require use of chemotherapy before the endocrine therapy. The category 3 patients are patients who are hormone receptor negative and HER2 negative. These are the triple negative patients who have metastatic disease. And the category 4 are the patients who are hormone receptor positive and they are HER2 positive, but can either be hormone receptor positive or negative. The other categories are the somatic breast cancer gene 1 or 2, and germline, the partner and localizer BRCA2 mutations and the HER2 mutations. For patients in category 1, it's advised to use the CDK 6 inhibitor in combination with endocrine therapy as first-line treatment. And these are usually used in combination with these are usually used with aromatase inhibitors in patients with postmenopausal menopausal patients with a de novo metastasis. This category of menopausal patients can either be from iatrogenic menopause or a physiologic menopause. So it is advised that a CDK6 inhibitors or aromatic inhibitors are used in this category of patients. For patients, also patients who have early disease progression or early relapse. Early relapse is defined as patients who have a recurrence within 12 months of adjuvant therapy. So this category of patients, a fulvestrant, which also an anti-estrogen, with a CDK4 in category 2 patients who have visceral crisis. It is advised to start with a chemotherapy first before other endocrine modalities are now employed. And the chemotherapy used generally the chemotherapy used are the taxane-based and azacitidine-based chemotherapy. And for the third category of patients who are the triple-negative patients, pembrolizumab and chemotherapy are usually advised, especially for those who have the PD1 expressing metastatic triple-negative breast cancers. For those with the germline BRCA1 or BRCA2 mutations, a platinum-based chemotherapy is advised for them. And this category also needs the PARP inhibitors, which the examples are the olaparib and the talazoparib. For the fourth category of patients, these are patients who are HER2 positive, but can either be the hormone receptor positive or negative. Those are the HER2. Treatment in this category of patients is to use trastuzumab, which is commonly used one here, and pertuzumab. Taxanes like docetaxel or paclitaxel can also be added. This category of patients are categorized. This group is categorized by the National Comprehensive Cancer Network as the emerging biomarkers, and these are the various treatments that are prescribed for this category. The challenges in West Africa. Management of breast cancer in West Africa is still at the basic traditional level at best. General surgeons are faced with high burden of advanced breast cancers due to late presentation, and there is paucity of health personnel to offer specialized care like general surgeries, physiotherapists, and oncology nurses. Limited numbers of radiotherapy centers or biotechnology laboratories are some of the challenges we face, and the outcome of out-of-pocket services are limiting overall access to quality health care. In conclusion, breast cancer is a heterogeneous disease, and the approach to its management is no longer one size fits all. The traditional management protocol of breast cancer is associated with high morbidity without a clear advantage of overall survival or disease-free survival, in addition to low self-esteem and depression that it may cause on these patients. Therefore, the current trend is to establish a standard of care by individualizing patients through a multidisciplinary approach. Thank you for listening. These are my references.
Hello.
Hello, sir.
Hello, sir. Good evening, sir.
Hello, Prof.
Good evening.
Good evening,
yeah.
sir. We can hear
Good
you, sir.
evening, Prof.
Good evening. Yeah.
Good evening, Prof.
Good evening.
Yeah,
Yes. So, Bash,
yes, sir. Sir, you can go ahead, sir.
you want me?
Yes, sir.
Okay. I should make comments first, or the people will talk first.
Sir, the people will talk first.
Good. So, Dr. Sholade,
Yes, sir.
thank you for a very beautiful presentation.
Thank you, sir.
I deliberately didn't say anything to you when I received the slides the other time because I thought you had done a good job. But let us hear before I say anything at all. Please, the discussion is open for contributions
Okay,
and
sir.
questions
Thank you,
from
sir.
the audience. You can do so by lifting your hand, comment in the
Hello, can you hear me?
Yes,
Can
sir.
you
we
hear
can, sir.
me?
Yes, sir. You are loud and clear, sir.
Yes. One of my network is off.
Oh,
Good. One of my network is off, so I'm using the standby device.
oh,
Uh,
sorry.
I haven't seen any hand up yet. Yeah, Peter
Uh,
is a comment.
Peter, is he?
Dr. Eze.
Good evening, sir. Hello, sir.
Yeah, good evening. Let's hear your comment or yes,
Thank you
let's
so much,
hear
sir.
your
Thank you.
question or contribution.
Thank you, sir. Thank you, Dr. Sholade, for your beautiful presentation. Thank you. A lot of information have been given, and I sincerely appreciate you.
Thank you, sir.
The what I wanted to ask is the options for those who are going for prophylactic mastectomy for the reasons given. What are their options for breast reconstruction? And of course, if for any reason a patient will benefit from mastectomy, because you have given us information on breast conserving surgeries and then the fact that there is no additional benefit when compared with mastectomy with or without that is breast conserving surgery with or without radiotherapy when compared with modified radical mastectomy. Now, for any reason, if a patient is having mastectomy, both either for prophylactic reasons or otherwise, what are the options of reconstruction that are now currently practiced? When you look at options for either implants or prosthesis, what are those options that are available for the patient? That's my question, sir. Thank you, sir.
Thank you, sir.
Okay, your question.
The network is-
Question, but we'll take it shortly. Can we have another question from Ghazali?
Yes, Prof. I have a question.
So let them note the questions. Ghazali, please.
Yes, sir.
Yes, sir.
your hand is up.
The network is, the voice is breaking, sir.
Yes, good evening, Prof.
Your hand now.
Yes, sir. Thank you very much, sir. Good evening, and I'm glad to be here. And yes, sir, I can. Hello, can you hear me, please?
We can all hear you. I think Prof
Yes.
some network challenges.
Yes, yes. So I think, can I go ahead and make my comment? I don't think Prof is online with us.
You can go ahead, sir.
Yes, thank you very much. Good evening, Professor. Good evening, colleagues. Dr. Bashir, thank you very much for extending the invitation to Aminu Kano Teaching Hospital. We are very glad to be here, and this is a very good initiative. Dr. Shalado, thank you very much for the presentation. It's a very good attempt, and it shows you have actually been actively involved in the practice in managing patients with breast cancer. I just have a few comments that I need to make. Thank you once again. Thank you. Now, when you were discussing the screening protocol for breast cancer, and one of the things that caught my attention is actually these the current trends in management of patients with breast cancer. So it is worth noting that in patients with high risk now, and patients that have had breast conservative surgery, magnetic resonance imaging is actually taking a forefront ahead of mammography in this category of patients. One of the problems that has been noticed with mammography in patients with high risk is the increased incidence of interval carcinoma between two screening period. And it has been noticed most of the time, by the time this interval carcinoma is diagnosed, actually an advanced stage carcinoma. So some of the guidelines are actually proposing the routine use of magnetic resonance imaging in patients with high risk of breast cancer for screening in patients with high risk. It is also important in patients that have had breast conservative surgery for follow-up because it plays a significant role in distinguishing between scar tissue and the recurrence of breast cancer in this category of patient. Excuse me. Then in your discussion of metastasis, I don't know if you have come across the concept of oligometastasis in breast cancer. Now, this is actually a common practice now in patients with solitary metastasis to the lungs or liver, or in patients with less than 3 metastases of a maximum diameter of 3 centimeters, limited to a segment of the liver or lungs. Now, in this category of patients, yes, they have metastasis, or if it is... Hello?
Hello, sir. We can hear you, sir.
Yes, sorry. I was distracted. Yes. So, in this category of patient, though there is a metastatic disease, now, if the primary pathology in the breast is amenable to curative surgery, in this category of patient, metastasectomy has been advocated, either pulmonary or hepatic metastasectomy. Even if it is not amenable at presentation, however, after neoadjuvant chemoradiation and it becomes amenable, so this patient, there are surgeons that are actually advocating for either synchronous metastasectomy at the same setting, or you do mastectomy first or breast conservative surgery, then within 6 months, you now come and do metastasectomy in this category of patient, either pulmonary or metastatic. So these are basically the two things I wanted to highlight. Once again, thank you very much, Dr. Shalade. Thank you, Bashir and colleagues, and we really appreciate Professor King Kenneth David Yawi. Good evening, all.
Thank you very much, sir, for the contribution, sir.
Thank you very much. That's a comment from Dr. Ghazali Umar, a hepatobiliary surgeon from Aminu Kano Teaching Hospital.
Sorry, I was briefly offline. I'm back.
Yes, sir. You are welcome. You are welcome back.
Yeah, different networks and 2 different handsets, and I still failed.
Yeah. You're welcome back, Prof.
Thanks.
Well, we're happy to have you.
Yeah, thanks. Right. I was just listening to Ghazali making a comment. Those patients are, by and large, very few to come by. But what you said is absolutely correct, what should be done. But what we normally see is more than 1 point of secondary metastasis.
Yes, sir.
Yeah, so that becomes very difficult to operate.
Yes, sir.
Yeah. Any other
Yeah,
comments?
thank you very much, Prof.
Yes, Prof. I have a comment.
Yes, yes. You have the floor.
Can I go ahead?
Yes, you have the floor.
So I would like to thank Dr. Solodaya for this wonderful presentation. And incidentally, I presented an update on management of breast cancer for NMA and M1. He stopped us so to speak. We are still having some few challenges. We usually have the role of the pastors and imam, which supportive. In the management, please. Such rules sometimes when disappear, and taxes is also be clear to them that these rules are not supportive. They are like having nothing to do with the survival of the patient. And then another is the role of the traditional healers. Please, like it or not, we are in Africa, and we are in patients prefer to go where they'll be told money, and then their breast will be in a lot of such patients who will go and come back with
We can't hear you again, sir.
metastatic disease, in which the surgeon has little or no it's available in Abuja.
So maybe you need to make your comment rather brief.
Or any of this kind of availability is yes, it's presently in doubt. And then finally, the immunohistochemistry. Remember our last update in Abuja around April, where we really publicized this immunohistochemistry. Up till now, it takes a long period to pull these specimens before they are taken. Then before they come back, the disease is at a more advanced level than it was at the time of diagnosis. Thank you very much.
Right. Thanks for your comment. Dr. Mohamed Daniel, you have a comment to make? You have the floor.
Thank you, Prof. Despite the late hours of the lecture, and also I would also like to thank the organizers, Dr. Bashir, and the presenter, Shuladoyu, for this opportunity. I just want to make one or two comments. My first comment is with respect to non-palpable breast masses, taking biopsy. You mentioned some highfalutin stuff that I think where localization perhaps can be done, but many times we don't have those no technique you are talking about. Dr. Agodin, Professor Agodin in University of Ilorin Teaching Hospital some years back published an article with respect to using hematoma localization of non-palpable breast masses, and then which involves taking the patient's blood sample, 1 to 2 mils, and then under ultrasound guidance, for those masses that could be picked by ultrasound, especially in the that could pick by ultrasound, but are not clinically palpable, injecting the 1 to 2 mils of blood into the mass under ultrasound guidance, and then waiting for 2 to 3 days for the hematoma to be formed, and then you now go in, make an incision, and then all you are just trying to locate a black structure that will have been stained by the blood that you injected 2 to 3 days earlier. I think it published. I think I will advise people, if we have not read it, to try and get access to the article and read. Perhaps in Zaga, I have used that on some occasions, and I've been able to get the non-palpable masses biopsied. The other thing I want to talk about is there are so many beautiful things that we could have done for our patients with breast cancer, but unfortunately, many of our patients still come late. So I think there is a need for us to start, not to stop waiting in the hospital for our patients to come to meet us. You have to look for a way somehow to look for a way of reaching out to these patients in the locality to let them know to see reasons why they need to come to us as their first option, not the prayer houses, not the traditionalist. And whatever it will take, I think that's something we need to start brainstorming on. Because if we don't get this patient early, no matter the stuff we have, no matter the advancement made all over the world, it will still be useless to us here in Africa. And I think one of the good things that will help in this is for patients who we are able to treat without having mastectomy. Of course, up to now, the fear of mastectomy is perhaps still one of the reasons why patients present late to us. So if you can look for a way of avoiding mastectomy, those ones that we are able to present early and we're able to manage them without mastectomy, we should keep on trying to look for a way of showcasing them. Anytime they come to the clinic, look for a way of making noise, let people around see them, know about them. Perhaps those information might trickle down back to society, and then we might start seeing more and more patients presenting early if they are aware that their breast may still be may not be removed. I'd like to thank again the presenter, the organizers, and particularly Professor Yawi for still finding time to still impact on us even this late hours. Thank you very much, sir.
All right. Thank you very much, Dr. Mohamed. I think we shall listen to Stephen Ghana. Yes. After that, we will allow Dr. Sholade to make a few comments. Then I would say what I want to say. Then we'll close. Dr.
Thank you.
Yes.
Thank you very much, Professor Yawi, for the opportunity. Thank you, Dr. Sholade, for that wonderful presentation. I'll make it brief. Two things. With the promotion of breast-conserving surgery and also breast reconstruction, we will, of course, rely more on radiotherapy, early radiotherapy for those patients who have undergone or were planning to undergo breast-conserving surgery. The challenge here is that we have very few centers, and we have to look into making those centers work and also opening new centers. It's a Herculean task. It's a big challenge because we know that to acquire a LINAC is a very long process. That's why we are always happy when centers like Maiduguri, who has come on board presently, I think we should find a way to liaise as a multidisciplinary team, not only in our local centers, but with centers far and near, so that when we have such patients who are suitable for these procedures, we can plan ahead so that we can get the best out of these centers. Secondly, with the promotion of reconstruction, I'm glad Dr. Daniel mentioned it. Here in ABUTH, that we are embracing intraoperative or one-stage reconstruction for patients who are suitable for the procedure. And it's something that has come on board, and we hope that with time, our patients can be showcased so that others who will tend to come late will actually accept that, okay, there is the option of reconstruction. So I can come for my treatment, I can come for my mastectomy or my surgery and have my breast reconstructed. Having said that, we should also note that there are patients whose main concern is actually the issue of recurrence. After surgery, how do I know early that my disease is coming back? And it can be a very tough challenge for women, especially high-risk women. So we must realize that counseling and the role of the psychologist or psychiatrist is also very important here. Also the role of the genetic counselor. So we should also endeavor to bring these people on board. There are patients who will not actually want a reconstruction. They would even not want a breast conserving surgery just because of the fear of recurrence. We must recognize them and we must listen to them and give them the option that be required. One of the main options being pushed presently, which you should add to your slide probably, Dr. Sholade, is the aesthetic flat closure. For a woman who does not want reconstruction, she just wants her chest to be flat, such that when there is anything like recurrence, it is easy to pick them. You don't have to wait for MRI or something. So aesthetic flat closure is one of the methods being propagated presently, even in the West, where you remove the redundant breast tissue, avoid dog ears, and you give a symmetric scar so that the woman can gladly wear her chest without feeling she has to wear a prosthesis or have breast reconstruction. Thank you very much.
Yeah, Dr. Ghana, very good comments you made. Your last point has a problem.
Okay, sir.
The scar you get depends on the size of tumor. When you are in so much trouble to even close the wound, then the issue becomes, which is one of the challenges we have, that you have such bulky tumors that aesthetic, it becomes a problem. Of course, when we're dealing with small tumors, what you have said is 100% correct, or tumors that have responded very promptly to neoadjuvant therapy, then yes, you can decide how the wound will close. But short of that, the issue Dr. Daniel was saying becomes very tenable, that we really need to find a way of, getting tumors early so that we can offer them the kind of treatment that is available elsewhere. Dr. Sholade, before I say what I want to say.
Thank you, Prof, for giving me the opportunity. Most of the discussions were just comments, but yes. Dr. Eze asked a question about why patients request for prophylactic mastectomy. I think it boils down to the issue of recurrence, just the fear of recurrence. That's why some patients opt for prophylactic mastectomy in the contralateral breast. But it's been done routinely in some places, but it's been advocated that there should be strict indications for this prophylactic mastectomy. I didn't get his other questions. I think the network was bad when he was saying, but others were just contributions.
Right. Thank you very much.
Thank you, sir.
Bash, let me say one or two things before you can round up. I'd like to say that the topic was quite broad, even when you're dealing with early breast cancer, it's enough trouble. When you're looking at advanced breast cancer, it's another. You're looking at metastatic breast cancer, your troubles have been increased. So, but I think that Dr. Sholade did a good job of trying to address all of that. Now, the role of neoadjuvant therapy is something that we talk about very seriously. Let me tell you my own challenge. Radiotherapy is not very easy for us to get. When you send a patient, there's already a long queue. And so in our practice presently, despite having radiotherapy in Abuja, we have adopted the habit of using neoadjuvant chemotherapy to try and downstage our tumors and also to buy time before the patient can eventually get onto radiotherapy when indicated properly. And I think that's something that is challenging. Why do we need to? We shouldn't really be waiting. Peculiar tumors presentations in our environment will require we also adopt certain peculiar ways of managing patients. And I think that's something, a challenge that we need to look at. Talking about early diagnosis, I think you did a good job. But let me say that if you work closely, and this is one of the good reasons why I think this meeting is important. We should work with radiologists who are very good, have excellent results with scanning of the axilla and scanning of local lesions. In other words, those specifically, working on breasts. They have a way in which they can help us make a diagnosis much, much earlier and be able to stage your tumors very well. I know in National Hospital, they have some crazy way of getting information about what is in the axilla for you before you take a decision. And I think it's a good idea to do so. Now, when you say this, we also talk about liquid biopsy. And this is an area I'm thinking that in the years ahead, if we work very hard, we might be able to pick up some things in the blood that can tell us when something is going to go wrong, well before something really goes wrong. So we can, and then try and make a diagnosis. I take your point on molecular classification very seriously. If you are looking at some of the journals we're looking at, almost every day, somebody is finding something new and trying to give another classification of these molecular subtypes. So it's a very dynamic field. Let's not be very dogmatic about what we're seeing. And I think it's important to note and keep abreast of what is happening continually. I saw Dr. George Ila on this call. On my team, I think since this year began, we have done about 5 or 6 bilateral prophylactic mastectomies. Bilateral mastectomies, and I think 3 or 4 of those specifically requested for prophylactic mastectomy. And I say this because it's not really something that is strange now among our patients. Ladies are becoming very, very enlightened. Unfortunately, genetic typing is what is being a challenge, but I'm happy to say it looks like even in UATH, this will start very soon. We now have a full-fledged molecular laboratory, and I think as we discussed last week, we will perhaps be offering routinely this facility to some of our patients. I agree totally that one of the reasons why this is being done blindly is the fear of cancer on the contralateral breast. And I can tell you that patients are requesting. Our last bilateral mastectomy, prophylactic mastectomy, was actually this last week. So it's not an uncommon, and we are being faced with that decision. And I agree with you totally, Dr. Chuladoye, that we need to make that decision in a more scientific way. PET scan is very expensive. Not everybody is going to go to Lagos to have a PET scan. So one of the challenges that we face is that we have to work without this. I can tell you one of the things that, Doc, I wanted to mention was why my network perhaps goes off, is to agree with you that for locally advanced tumor, we really need to individualize and we need to work with others. I don't want us to become champions in this time and age when everybody is putting their hands together to work. So it's something that we need to promote on our cancer, multidisciplinary cancer boards in our various hospitals. Dr. Nania was saying that contralateral is thinking that perhaps for some of these patients, their fear of tumor on the contralateral side may be justified. That is a good point. And so, Bash, the last thing I'd like to say is that Chuladoye didn't include this, but one of the social problems involved in mastectomy, which is hardly spoken about, is sexual adjustments. And I think we are not really equipped as surgeons to embark on this, but because we don't have a lot of, oncology nurses and social welfare people working with us, we dabble into this, but we don't do it as well as it should. This is an evolving problem that requires our asking others to help us. Adjustment. After removing the breast, a woman's life becomes almost, sexually very dull. And we need to help them before and actually speak with husbands as much as possible to counsel them to make some adjustments. Adjustments are adjustments. They are not, doesn't mean back to normal, but at least life can go on in a much smoother way. So let me hand over to Dr. Bashir to thank him very much for asking me to coordinate this, moderate this discussion. Dr. Dadez, Dr. Dadez, would you want to say something before Bash takes over?
Good evening, Prof. Good evening, everyone. I think everything has
Dr. Ila, just one sentence each if you have. Yeah.
All right. Wonderful presentation, Dr. Sholadaye. I think yes, it has been, everything has been said. Just to a word about fertility concerns. You know, it's one of the things that we do these days to try to conserve the eggs for childbearing women. You know, unlike in the past, it's not something we do come about now. It's something that's being considered. So the gynecologists have a role to play with respect to this. Otherwise, I think it's a very good presentation. Well done.
Yeah. Thank you, sir. Thank you very much, Dr. Ila, and then Dr. Ogbo. Anything you want to say? Ila?
Good evening, Prof. Thank you very much, Dr. Soladoye. You gave a very powerful presentation, as if it was a very heavy rain that fell this evening. However, like my boss have said, I think we also need to work more upon our investigative modalities, which the federal government, if there is a way, should help us too. Because if we can get 1 or 2 centers around that we know that this can make provisions, it will help us. What of fund? Like Prof said, out-of-pocket funding is very difficult on the part of our patients. Currently, like I was reporting in the last meeting that I had with Roach, we had a young lady who cannot even afford this targeted therapy, and she's HER2 positive. So we need funding also to help us in the management, as most patients are indigent. Otherwise, your presentation is beautiful. There are a lot of terminologies, a lot of investigations that were very new, and we have to see how we can make the federal government to get this information and help us through. Thank you, Prof, for giving me opportunity to say 1 or 2 things.
Thank you very much.
All my colleagues.
Thanks. Okay, Bash, over to you.
Thank you, Prof. Thank you, everyone, for participating in this wonderful presentation by Dr. Sholadaye, Senior Registrar with Federal Teaching Hospital, Katsina. Next week, our presentation will be on principles of organ transplant. And we'll have a registrar taking that topic. And upper week will be classification and management of thyroid malignancies. So the information will be shared on various platforms so that we'll all come together and share ideas and make comments and contributions. Thank you very much for joining us. And I'll also appreciate Prof for his untiring effort in medical education, the development of medical education in West Africa and worldwide. We really appreciate you, sir, for your untiring effort.
Thank you very much.
Yes. So,
thanks.
Thank you all.
It's my pleasure.
Comments. So we are going to have principles of organ transplant next week. Thank you, and the link will be shared to various platforms. Thank you, sir. Thank you all. Good night, everyone.
Right.
Good night.
Thank you. Thank you, sir.
Good night. Good night.
Restful, sir.
Good night. Thank you, everyone.
Go,
Thank you. Have a nice day.
everyone.